Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by our senior colleague, Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of Nath Arua and the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 404 of our pharmacotherapy series, which majors in headache. The first question reads, LPO is a 27-year-old female presenting to her primary care physician, abbreviated as PCP, with a chief complaint of a severe, throbbing headache. LPO reports that headaches began 18 months ago, but during the past 3 months, headaches have been occurring with greater frequency, approximating one episode every 2 to 3 weeks. She further describes bilateral headache pain, occurring, without warning, and coinciding symptoms of nausea and vomiting, photophobia, and suboccipital pain. Prior episodes have been self-treated with acetaminophen 500 mg, that is 4 to 8 tablets per episode as needed, with variable efficacy. Her past medical history is significant for generalized anxiety disorder, gastroesophageal reflux, and seasonal allergies. Current medication usage includes levonorgestrel co-formulated with ethinyl estradiol 0.1/0.02 mg by mouth daily, venlafaxine XR 75 mg by mouth daily for generalized anxiety disorder, abbreviated as GAD, and omeprazole 20 mg by mouth daily for 2 months for recent onset gastroesophageal reflux disease symptoms. Her social history is negative for both tobacco use and illicit substances. LPO reports the occasional consumption of alcohol, stated as 1 to 2 cocktails after work on Fridays, in her own words. As headaches have occurred with greater frequency, absenteeism from work has resulted, and this issue has prompted a visit with the primary care physician. Physical and neurologic examinations are unremarkable. What subjective and objective information is consistent with a migraine diagnosis? And how do these signs and symptoms differ from tension-type headache? Symptoms reported by LPO are consistent with migraine. A study by Kelman addressed migraine location, reporting unilateral character in 67% of study subjects and bilateral character in nearly 24%. For LPO, migraine location would not be a differentiating characteristic between migraine and tension headache, because tension headache is more commonly associated with bilateral character. Pain quality, described as severe and throbbing, is consistent with migraine and precipitates interruptions with daily activity, e.g., absenteeism from work, contrasted with tension headache, which is associated with sensations of tightness. Similarly, the occurrence of nausea, vomiting, and photophobia more appropriately aligns with migraine. Migraine prevalence is higher in female patients than in male patients, approximating 17% with a cumulative incidence in females of 43%. Migraine prevalence within the range of 18 to 29 years has been reported as nearly 21%. LPO's sex and age would be compatible with prevalence data, although it should be noted that a 28% prevalence statistic for females has been reported in the age range of 30 to 39. My next question to you reads: which characteristics may be classified as precipitating factors, or triggers, for migraine pathology? What are possible precipitating factors in LPO? Factors involved in precipitating migraine should be routinely assessed for all patients. Assessment should address factors within a patient's medical history, medication usage, social history, and environment. LPO's medical history is significant for generalized anxiety disorder. She denies the usage of tobacco and illicit substances. She does report the occasional use of alcohol. Alterations in neurotrophic factors and an increase in anxiety symptoms have been demonstrated in migraine patients. Such evidence imparts value to assess this aspect of LPO's medical history. While the consumption of alcohol should be addressed, the linkage between alcohol consumption and precipitating migraines is less clear. The potential provocation of cortical spreading depression, an electrophysiologic factor underlying migraine pathology, in association with alcohol has been suggested. Although not reported by LPO, an evaluation of diet may provide useful information in determining migraine triggers. The evaluation of dietary patterns and quality has yielded disparities, reporting lower quality dietary intake in migraine patients. My next question to you reads: are further diagnostic and laboratory tests indicated in the case of LPO? The most important diagnostic evaluations of patients presenting with headache should be based on a thorough medical history and physical examination. Imaging, e.g., CT scans, MRI, is generally not required in the context of uncomplicated migraine. The report of symptoms by LPO is consistent with migraine and is sufficient for diagnosis. Her symptoms are not associated with a secondary cause, such as trauma or other injury to the head or neck, and her neurologic examination is unremarkable. Similarly, without reason to suspect subarachnoid hemorrhage or symptoms secondary to meningitis, lumbar puncture would not be indicated. Clinical manifestations that may warrant neurologic imaging to identify artifacts or structural anomalies include coordination deficits, localized neurologic pathology, sensory manifestations, an abnormal neurologic examination, or the presence of atypical headache characteristics. Further, a change in headache character and headache onset with advanced age warrants neuroimaging. The next question read: what are the goals of therapy for the management of headache in LPO? The approach to management and the treatment objectives for LPO include resolving the acute symptoms of pain, nausea, and photosensitivity, educating LPO on both prescription and self-care treatment, addressing the contribution of past medical history and concurrent medication usage to headache episodes, and identifying potential triggers. The next question reads, what is the most appropriate recommendation with regard to the use of acetaminophen to treat headache episodes in LPO? LPO has confirmed self-treatment of headaches with acetaminophen, and in such instances, it is critical to not only evaluate each patient's potential for self-care, but also determine whether self-care treatment options can effectively and safely manage the diagnosis. Reported efficacy of acetaminophen has been mixed. Evidence does support acetaminophen efficacy in the migraine patient, and comparisons of acetaminophen with placebo yielded a nearly 20% difference in headache resolution. However, a study evaluating the parenteral administration of acetaminophen for acute management found no significant difference in efficacy versus placebo. Considering LPO's report of variable efficacy and increase in headache frequency, she is not an appropriate self-care candidate, and continued, routine use of acetaminophen to manage acute episodes is not recommended. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. On behalf of our senior colleague, Dr. Nath Arora, I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 405.